This is Aging Forward, a podcast from Mayo Clinic about the science behind healthy aging and longevity. Each episode, we explore new ways to take care of our long-term health, the health of our loved ones, and our community, so we can all live longer and better. I'm Dr. Christina Chen, a geriatrician and internist at Mayo Clinic in Rochester, Minnesota, and this episode we are talking all about arthritis. About 1 in 4 adults experience some form of arthritis, and that number only increases with age. It's a painful disease that causes swelling of the joints that often limits mobility. According to the Arthritis Foundation, there are actually over 100 different forms of arthritis and related diseases. But today, we're focusing on 3 of the major types: rheumatoid arthritis, osteoarthritis, and crystalline arthritis. In this episode, we are joined by Dr. Elena Myasoedova, a clinical rheumatologist at Mayo Clinic in Rochester, Minnesota, who has spent her career helping people with arthritis get the right diagnosis and treatment. She'll walk us through the different types of arthritis, their root causes, and what we can do to help prevent and treat this often debilitating disease. Dr. Myasoedova, thank you so much for being here today.
Thank you for having me.
Yeah, so before we get started, you are a rheumatologist. Tell us what a rheumatologist does and what is your role here at Mayo Clinic?
So I'm a director of inflammatory arthritis clinic in the division of rheumatology here at Mayo Clinic. In our clinic, we see people with different types of arthritis: inflammatory arthritis, degenerative arthritis, conditions that are related to crystalline arthritis, such as gout. So all different kinds of arthritis. In general, division of rheumatology takes care of people with autoimmune conditions that include systemic rheumatic diseases such as lupus. So it's really a wide spectrum of diseases that are driven by autoimmune, mainly autoimmune mechanisms, but also some other conditions that are not necessarily autoimmune, but also belong, such as gout, for example.
So let's start with the basics here. Whenever I ask my patients, how are you doing? They're always like, I feel great, but I'm just getting arthritic. And it just seems like arthritis is almost synonymous with aging. They just feel like that's what's supposed to happen over time. What exactly is arthritis? What's happening in the joints over time? Why is it so common in older adults?
So arthritis, the word itself, comes from 2 words put together, which is arthros, meaning joint, and itis, meaning inflammation. So inflammation in the joints is arthritis. And so inflammation in the joint can occur under different scenarios, and that include scenarios such as autoimmune disease, for example, rheumatoid arthritis, or degenerative disease such as osteoarthritis, which is what majority of people acquire with aging. But indeed, as we age, arthritis becomes more prevalent in the population. And on average, across all ages, every 4th adult would be affected by some sort of arthritis. And above the age of 65, this proportion increases to 50-60%. So it is quite prevalent and quite widespread. But indeed, as we age, this becomes more of a problem.
Right. And you alluded to this earlier, but there's the different categories between degenerative and inflammatory. Can you kind of walk us through what's the difference between all that?
Yeah, the difference is in what mechanism starts the process.
Okay.
So with autoimmune inflammatory arthritis, the process starts with immune system mistakenly recognizing host tissue, so patient's tissue, as a foreign tissue and starting to attack it, resulting in inflammation. Osteoarthritis is a different story where with aging, cartilage is not able to recover as much and starts to degenerate. That results in local inflammation just because of the stress and sort of grinding in between the bony surfaces of the joint. So the inflammation comes secondary, and it's generally localized and low grade. In crystalline arthritis, such as gout or pseudogout, there is a deposition of crystals of monosodium urate in the case of gout, or calcium pyrophosphate in the case of pseudogout, that deposits in the tissue and causes irritation, also fairly localized to the site where those crystals are deposited. And that causes autoinflammatory reaction, resulting in swelling, pain, and so on. So all these kinds are different, but the uniting mechanism is that they affect joints, so arthritis with inflammation.
Mm-hmm. It just seems like the joints tend to attract things. You're attracting like crystal deposition. It seems to be an area where things tend to congregate. And when it does, it just becomes inflamed. That's an interesting perspective.
Yeah, in fact, we understand a little more, especially about the autoimmune disease, where actually the initial site where the disease starts is not the joint itself. This is a fairly long and protracted story where it starts with the genetic risk factor, so genetic predisposition, and then with time and additional trigger factors and sometimes hormonal background or age category, patient may acquire a certain type of autoimmune arthritis. And so mucosal surfaces such as lungs, periodontal, oral cavity, periodontal disease, or sinuses are frequently the starting points for arthritis that is autoimmune.
That's interesting. Mm-hmm. Yeah, thank you for explaining that. I didn't realize that it could start from elsewhere and then sort of make its way around the body and end up in the joints. Would you say that degenerative arthritis is what you see most commonly in your practice, or do you typically see other types? Because I imagine by the time people get to you, they've already gone through primary care and they can't figure out the cause of the arthritis. So what's the most prevalent thing that you see in your practice?
So degenerative arthritis is definitely the most prevalent type of arthritis in population. It's mostly managed by primary care providers, and we frequently see these people when they have osteoarthritis as a condition that accompanies autoimmune disease.
Yeah.
We generally don't follow people for osteoarthritis itself, but we certainly can help differentiate between the types of arthritis.
Okay. And you mentioned earlier that genetics may play a role, but why are some people more predisposed to developing arthritis compared to others? You see 90-year-olds out there running marathons. They may have arthritis, but not have it bother them. You see others in their 50s, and they're just so almost disabled from it. Like, where do things go wrong in the middle, and what are some other factors that lead to a higher risk?
Yeah, there's a number of them, and it also depends on kinds of arthritis. So, for example, for osteoarthritis, there is a combination or a formula for it would be mechanical load plus any sort of condition that make that joint more vulnerable. And that can be just how a person is built, or maybe they had a previous injury or trauma to that joint, or maybe they have inflammatory arthritis in that particular joint. This vulnerable joint would be more likely to bear signs of osteoarthritis or degenerative arthritis. And with osteoarthritis, the joints that are involved most are the weight-bearing joints, and that would be knees, hips, rather than, for example, shoulders or elbows. There's also hand osteoarthritis that is also a condition, and indeed our hands are involved in many very fine movements and frequently are subject to stress in terms of the number of activities they're involved with. That's why we suggest, if there is a need to carry something, not to carry with a smaller joint, but to put the load more on the larger joint. So not to carry with your fingers, but more with your arms, for example, to decrease that burden on the smaller joints.
I see. So you mentioned like when that you sustain too much mechanical load, that would be influenced by, for example, weight, but also prior injuries too. If they were involved in an occupation that involved a lot of physical activity, is that also a risk factor as well?
Exactly. So repeated use of the joint and overuse of the joint would lead to osteoarthritis or development of changes in the joint in that patient. But also, as you pointed out, actually very rightfully, increased weight, so obesity, affects significantly the risk of osteoarthritis. Every extra pound of weight results in 4 extra pounds of load on the knee with every step.
That's incredible. So 20 pounds of weight loss equals to 80 pounds off your knees. I feel like when I put that into a number perspective, it just hits differently,
Yeah.
And so I think that's a really great way to counsel people and empower them is that even 1 pound of weight loss makes a big difference in the long run.
Exactly.
And the most common symptoms I hear are, things are getting a little bit stiff, more pain in the joints, maybe less range of motion. I feel like that gets sort of pushed aside because it just seems like a normal sign of age or a normal process of aging. My question is, what is considered normal and okay to observe versus when should someone probably go through some sort of evaluation earlier on, not push it out too far down the road?
Yeah, the devil is in details, and quantifying all of these symptoms by asking patients specific questions is very important. And a lot of that comes from patient's story.
Yeah.
So if we are asking about pain, we are interested in what causes pain or when pain is more pronounced. Is it in the morning, which would be more towards inflammatory arthritis, such as rheumatoid arthritis, for example, or towards the evening or with activity, that would be more suggestive of degenerative arthritis, or maybe after eating something specific, like having a glass of beer, that would be more towards crystalline arthritis, right, with episode of gout. So history is very important. Stiffness that you mentioned, we quantify as well. If the stiffness lasts 1 hour or longer, it's more suspicious for autoimmune inflammatory arthritis as opposed to stiffness that lasts minutes after awakening and then goes away as we start moving. If only 1 or 2 joints are involved and these are weight-bearing joints, there is a likelihood that it could still be osteoarthritis. However, if there is multiple joints and this becomes more of a symmetric process, that would probably turn our attention more towards rheumatoid arthritis. If there is swelling of the joints, that has to be evaluated by a physician to recommend specifically whether or not it is more concerning for one or the other. We can also do analysis of synovial fluid, particularly from larger joints, to understand how inflammatory the fluid is, if there is crystals in the fluid that suggest of gout or pseudo-gout, and that all helps direct the care. Also, the duration of the symptoms themselves. So if it's just acute onset and self-resolving situation versus this is something protracted and continuing over 6 weeks with these inflammatory symptoms involving more than a couple of joints and resulting in prolonged stiffness, that would be more suspicious, certainly for a situation that needs to be referred to a rheumatologist.
So it sounds like we as primary care physicians should dig a little bit more about the symptomatology, because if we don't get those details, then it's assumed that it's going to be okay, or this is just a natural part of the aging process. But like you said, how long is it happening for? Is it involving so many joints that it's impacting their function? Like these things, I think, are really important to talk about earlier on so that we can help identify, is this going to be a serious issue later on?
Exactly. And a lot of times we also look at the patients themselves. What is the age category, the gender, what is the occupation, what are the predisposing factors, what were the circumstances when this situation developed? Was there an injury? Was there a sickness perhaps? Could be an underlying cause for reactive arthritis, which is another kind of inflammatory arthritis. So all of these are important to consider. And literally with rheumatology, history is one of the most important parts of understanding what's going on with a patient. And next, of course, exam.
Yeah. You mentioned osteoarthritis. The most common joints are the weight-bearing ones, right? Like the hips and knees and hands that are more active. But we also need to be more active too. We can't overdo it, but we can't underdo it as well. So how can we just be more thoughtful about protecting our joints, slowing progression? What are the most effective non-surgical strategies that we should be doing in our 30s and 40s, for example?
Yeah, that's very important. For someone who already has some problems with the joints, sometimes it's helpful to limit the exercise to lower impact exercise, such as water aerobics, cycling, or walking instead of running marathons. But for healthy people in their 20s, 30s, really any exercise routine that makes them feel comfortable is fine. What I was taught when I was in PM&R, physical medicine and rehabilitation rotation here at Mayo Clinic is if it hurts 2 hours after and or the next morning, then it's time to cut down on the activities that you are doing. So that gives you a little bit of estimate as to how one can react to whether they are doing too much or they are on the right track.
And just a quick note on medications or supplements to preserve joint health. There's all sorts of things, chondroitin, glucosamine, collagen peptides nowadays. Is there a magic combination that seems to help beforehand, or is that more anecdotal?
Yeah, unfortunately, I don't think we have very strong evidence on any of these.
Yeah.
And a lot of them are not FDA approved, which means that there's not been enough studies to really compare and evaluate the effect of these supplements. A lot of times we would say that you're okay using them, but we cannot guarantee that there's going to be any benefit from them. So if you feel better with that, that's fine, but always report it to your doctor because some of these substances may interact with the medications that you are taking for arthritis or for other diseases, and that becomes a problem at that point.
Let's talk a little bit more about this category of inflammatory arthritis, like rheumatoid and psoriatic. What causes the immune system to attack the joints in these diseases? You talked about there's a trigger usually, but what's going on there? Why does it happen?
Yeah, it's called loss of immune tolerance. So an immune system normally tolerates and recognizes the tissues in your own body as your own, right? But then with certain stimuli and with genetic predisposition that we discussed, this immune tolerance can be broken, and then the tissue that is your native tissue can be recognized as a foreign tissue, and that starts this process of autoantibody formation and attack of the native tissue with resulting inflammation and so on. So this is a really complex process, and what we understand is that the process starts with genetic predisposition, but then it may last several years to decades to actually manifest eventually in a clinical picture of arthritis. So it's really very slow developing process, and by the time we recognize that a person is sick, there's a lot of history that has happened that led to that, and a lot of that is actually in the lifestyle domain, including keeping up with your oral health routine, making sure your periodontal health is good, making sure there's no smoking, avoiding the air polluted areas, making sure that there's no recurrent infections of upper airways, for example. Gut microbiome plays an important role as well. So what we eat is also important in a sense that healthy eating, it's frequently called anti-inflammatory diet, but really it's healthy eating. It's just avoiding ultra-processed foods, sugary drinks, eating more towards a lower fat diets, dairy products, and so on, avoiding red meat, for example. So all these general rules apply and help.
Yeah. And as you're talking through this, I'm thinking of specific patient stories that really stand out to me that was caused by either some sort of health trigger or relieved or improved with their lifestyle. Is one woman, perfectly healthy, developed shingles, a big case of shingles involving her entire arm. And after that resolved, ended up getting rheumatoid arthritis like 6 months later. I also recall a woman who, after pregnancy, it was a very traumatic pregnancy, about a year later developed psoriatic arthritis. It was the most bizarre thing. They were all perfectly healthy beforehand. And the third case that comes to mind is a gentleman who had rheumatoid, lost like 120 pounds through lifestyle diet, and it got better. And so there's so much influence of our external environment and the things that we go through and the health issues that we go through that I think, again, has impact on our immune system.
Yeah, definitely. It's this so-called three-hit theory where genetic predisposition plus environmental trigger plus this hormonal status or age come together, and this perfect storm results in a manifestation of diseases. So in your second example, that was, a perfect example where postpartum women are at increased risk of development of autoimmune inflammatory arthritis
Interesting.
during breastfeeding. It's not uncommon, and we know that there's these vulnerable times, either postpartum time or menopausal time, which associate with peaks of incidence of autoimmune inflammatory arthritis, specifically rheumatoid arthritis, but psoriatic arthritis in your example as well.
Yeah, very interesting. And then the long-term joint damage in either degenerative and inflammatory, is one worse than the other? Do they all kind of end up in the same outcome? And how important is that early diagnosis to prevent that permanent joint destruction?
So particularly for autoimmune inflammatory arthritis, the damage is essentially imminent. So if not treated, and we have a concept of window of opportunity, which essentially is 3 months after the onset, ideally, or the diagnosis of inflammatory arthritis, if we don't start disease-modifying antirheumatic drugs, DMARDs they are called, then the outcome is not as good as opposed in individuals who initiate those medications very early on. And we have several of these medications that we can use, but really the key is to get the correct diagnosis early, initiate the effective medication early on, and then follow up with your rheumatology physician or rheumatology provider to make sure that the medication is doing what it's supposed to do, there's no dangerous side effect, and to make sure that you are getting back to your normal self after initiating that medication. So without those, unfortunately, there's a really high risk that there will be significant damage to the joint and limited function. In the past, we've had more joint replacements than now, just because we didn't have availability of these effective medications that can prevent joint damage. So we are in a better position now. But in some cases, particularly when treatment is started later, the disease is harder to control.
Right.
With osteoarthritis, it's different, and it does depend on multiple factors, and generally, the damage is progressive. We don't have medications that reverse this damage from progression, but we can use physical activity, weight loss, or maintenance of healthy weight to counteract this trajectory of osteoarthritis.
And my observation is that there's a lot of treatments out there with the new biologics that are available. I feel like every time I turn around, there's a new one. And so they've gotten more refined, I think, over time.
Definitely, yes. We have over 15 medications now to treat, for example, rheumatoid arthritis. We are doing much better, but still there is a category of patients who would not respond to any of these medications, and they are continuing to have symptoms despite having tried a number of options. So that still is the case, but this is minority. This is 10-15% of patients. And the rest of them enjoy benefits from the medications, and frequently we can get patients into remission or at least low disease activity. And ideally, of course, we want them to be in sustained remission, which is remission lasting 6 to 12 months.
Yeah, it's just nice to know there's so many options and that it is manageable, it is controllable. I have many people in their 80s and 90s who have a diagnosis of rheumatoid, and they're not on any medications because they've been treated. It's quiescent, they're doing well, and they're very functional. So it's nice to know that it doesn't have to define you, right? And that you can do very well with it.
Yes, that's very true.
Yeah. Let's talk about the last category, which is metabolic arthropathies. Gout and pseudogout, you mentioned it, seems to attack certain joints, and it's a little bit different than the degenerative and the inflammatory type. Can you give us an overview about what gout and pseudogout is?
So these are indeed different types of arthritis. And so with gout, the reasons for these disease and disease manifestations is either overproduction or underexcretion of uric acid.
Okay.
And this can come about from several different mechanisms, including genetic predisposition, for example, to this condition, particularly in younger individuals, or with certain lifestyle and habits, such as overconsumption of high purine foods that then result in higher levels of uric acid. And that would include processed meat, shellfish, sugary drinks, beer and spirits. So these type of things.
I've always been curious why gout always seems to make its way into the toes, knees, like wrists. How come it doesn't go to the hip or spine or, like why those joints specifically? Do we know?
Monosodium urate crystals are crystals.
Yeah.
And so the crystallization tends to happen more commonly in locations that are more distant from the core, right? Because the core is warmer generally. And so anywhere that is in the extremity, particularly in the feet, is more common than anything that is closer to the axial areas. Although currently, because we have better imaging, we understand that uric acid can collect literally in the axial spine and in the sternum as well, but it's much more rare, and it requires higher burden of this monosodium urate crystals, longer duration of this disease to collect in these spots. So the classical ones still fairly commonly relate to extremities, hands, and feet.
Got it. Very interesting. Thank you for explaining that. And we have one last question, which is actually for you, our experts. We love to hear about how our experts view healthy aging and how you personally live well. So the question is, what does aging forward mean to you, and how do you personally age well?
Aging forward for me means that I embrace life with curiosity, resilience, but also intention, and not just counting the years, but also understanding that every single moment is unique, and adhering to healthy lifestyle and exercise routine and moving forward with very much of positivity and hope. That helps me, and I think my family, also to enjoy every moment in life.
Well, thank you so much, Dr. Myasoedova, for this conversation and for helping us really understand why arthritis happens at a cellular, molecular level. And that's one of our main goals of this podcast, is to really help people change their health course by staying more informed about what's actually happening in their bodies. Understanding your joints is the first step towards protecting them, right? So thank you for being part of that mission today.
Wonderful. Thank you so much for having me. It was a pleasure.
So that's all for this episode. Hopefully you're feeling a little bit more informed, inspired, and empowered. If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272, and we might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. And to learn more about arthritis, you can check out our show notes, where we have included a link to the newly revised and updated book, Mayo Clinic Guide to Arthritis, Managing Joint Pain for an Active Life. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, stay curious and stay active.
This podcast is for informational purposes only and should not be relied upon as medical or legal advice. Always consult with a qualified healthcare provider for any medical questions. The appearance of any guest does not imply an endorsement of them, their employer, or any entity they represent. The views and opinions are those of the speakers and do not necessarily reflect the views of Mayo Clinic. Reference to any product, service, or entity does not constitute an endorsement of or recommendation by Mayo Clinic.